Our Bell-sponsored luncheons are a great opportunity for us to express thanks to all of you who are generously supportive of our hospitals throughout the year, and to share all kinds of information about what is going on in our clinical programs, with our research activities, and with healthcare education in our community. It's been an exciting few months for University Hospitals Kingston Foundation. Our board of directors has been working on a new mission and vision statement for our foundation, and in fact we have Sherry Robertson, who was a member of the committee who worked on that with us today. Hi, Sherry. And so I'm pleased to share with you our new mission statement, which is inspiring generosity for the health of our families, our region, and beyond. In thinking about how to craft a mission statement, our board members really felt that our focus as a foundation is on inspiring generosity, but in this community, we have the benefit of knowing that our families will almost certainly benefit from the hospitals that are supported by our foundation, and we do recognize that our education and research mandate reaches well beyond the region. In addition, our board has adopted a new vision statement, and all of you are going to help us realize this vision in the decades ahead, and that is exceptional health care made possible by fully engaged, generous people and communities. And I would certainly count all of you within that group. I think that all of you will be aware that our luncheons are held 3 times a year and that we are generously sponsored by our friends from Bell. We expect that Jason McDonald, who is the regional sales manager for this area, will be with us shortly. We were expecting him, and if I have the opportunity, I will introduce him a little bit later. Today's focus will be on dermatological services. As I rounded the room before we started today, I heard from a number of you that you've received care at the dermatology program. Some of you have had to seek care in other communities over the last number of years because we've had not an adequate number of specialists to provide the service needed in this community. We've had a bit of a renewal and refreshing of the dermatology program, and we're really thrilled about it. Part of that was enabled by support that the community gave through the Relay for Life that helped us to fit out a new dermatology clinic, and there's some other exciting things going on that you will hear about from our guest speakers a little bit later.
I'm going to start with what do dermatologists do, because based on Grey's Anatomy and other shows like that, I don't feel that we have a very great representation in the media. All right. So it's really the intersection between internal medicine, surgery, and we see people at all stages of life. Skin disease is very common, and it can be life-threatening, not just from what people commonly think of would be skin cancers, but also skin can be a window into what's happening in the body. And there's a huge impact on quality of life. So dermatology encompasses a lot of things, like infection, this is shingles, cancer, eczema, psoriasis, drug reactions. We see a lot of systemic diseases, and I mean, I could go on and on and on, but I won't. So this would be a skin cancer like a basal cell carcinoma, melanomas. These are things that we see regularly. So we've already had a nice introduction of the 3 of us, so I won't go on to that. You've heard quite a bit about me. I did come from Montreal, where I worked at the Royal Vic. You might have heard of that because I just recently moved that hospital to the new hospital. And I arrived in Kingston just over a year ago. So in my introduction, you heard a little about my research interests. So my PhD is really stemming from my master's work, where I looked at the eczema gene, and people who tend to have this eczema gene also tend to have wrinkly palms. And usually at this point in my talk, that's when everyone starts looking, especially the ones who have eczema or food allergies or asthma or hay fever in their families. And we can see this wrinkly palms even in very young children, which is a nice indicator of whether or not they might carry this mutation. I'll just put a short summary that we found it in peanut allergy, which was actually quite a big deal. And that's because there hadn't been anything found in terms of peanut allergy genetics for probably about a decade. And it was also the strongest genetic risk factor at that time to be found. So we had our own Wiki News page too. So that has led me to my current research project, which is looking at, is it a skin barrier defect, which we see in eczema that's leading to sensitization to peanut, and is it because anyone who's made a peanut butter sandwich, it's hard to not get peanut butter on yourself when you do it. But also birch pollen tends to share homology, so those proteins look similar to proteins in peanut, and so that's one of the other ideas of why people seem to be getting more peanut allergy. As mentioned, my other research interests are looking at clinical practice guidelines. So we're just waiting for revisions of our acne clinical practice guidelines in the Canadian Medical Association Journal, and we're currently working on the rosacea clinical practice guidelines. And since coming to Queen's, because Queen's has some other unique research opportunities, one of these is the epidemiologic database ISIS, and I've been doing some work on skin cancer there. So I also wanted to present a progress report on what we're doing clinically. When I arrived a year ago, there was no division, no clinic, no secretary. I had no office. I had no hospital privilege when I first arrived, because you kind of have to be here to get that. And somehow someone still was able to send me referrals. So there's definitely a lot of excitement about having dermatology here. I guess there was a rumor going around that there was some dermatologist arriving, and people were very, very excited. And I think that underscores the need that there is in this area. So our clinic is located currently in GMANS 5 in Hotel Dieu. I still can't pronounce it the way people pronounce the Dieu. Coming from Montreal, I still call it the Dieu. But we also have phototherapy Monday, Wednesdays, and Fridays. And we also work out of the Kingston Regional Cancer Center on select days. And we will be expanding those now that we have Dr. Moran with us. We provide service to inpatients in the Kingston General, and we also are in pretty high demand. I think in this month alone, between 20 lectures between all of us. So there's a lot of requests for teaching. In terms of number of patients we see, just in April, we saw 1,000 patients. So that's visits alone. About half of those are new. So we are pretty high volume. And part of that is because we're dealing with like a 10 to 15-year backlog. I mean, I don't know how Ruth McSween managed for so long alone, because there's just such a huge need. And our current wait list, despite trying to pump these volumes, increasing our efficiency, and it's been really great how we've had the support from the hospital administrations in trying to get everything set up and set up quickly. We still have a huge need, so we still have like 900 people waiting to see us, and so we know that there's a lot more to be done. So I just wanted to show you some photos of our nice setup that we have. We are located on GMANS 5. We always like to have the rooms on the left side because those are the ones in the window. And dermatologists are very particular about light. So we like natural light. Sometimes we don't want light. We're like, we want the room with no light because I need a woods lamp exam. So we're very particular about light. We have these procedure rooms available to us. So if we're doing big excisions, we have a stretcher here. It would be nice to have a surgical bed just because sometimes it's easier to position people that way. But this is a nice room to work out of when you're doing something a bit bigger. This is our trusty liquid nitrogen tank, which needs a special container or it will explode. And then some of you may be familiar with this instrument of destruction. So some of you may have encountered this if you've visited a dermatologist anywhere or been treated even by your GP. This is our light therapy unit, which is computerized. And our nurses actually are in charge of this, and they put the patients in, they put in their treatment regimens, we prescribe it, and then we follow up with them as needed. The nurses also do a lot for us in terms of, we, as you can imagine, see a lot of skin cancer, so we have to do a lot of biopsies. So they set up our trays for us, they make sure that the specimens get to where they're going, labeled properly, all of those little things that don't seem like they're a big deal, but they are actually the biggest possible deal, right? When we do surgeries, we sometimes need our cautery machine as well. And we do a lot of teaching of patients in terms of what to watch for a variety of different conditions, and the nurses help do this for us as well. So that was our full body phototherapy unit that I showed you. This is our hand-foot phototherapy unit, and although we've got it, and we've actually got probably about 20 people waiting to use it, the problem is that we just don't have enough staff to support this. Just when you think about the volumes of what we're doing, how many people we're seeing, it does take some time to, make sure people are positioned properly, we go over their medications, all this stuff, make sure that you're wearing goggles, everything, and we need nursing support for that. So nurses do a lot for us. We've got some great nurses up on our floor. They are in high demand in a polyclinic, so it's not just us up there. There's other specialties, and we sometimes have to find them and steal them when we need stuff done. In terms of dermatologists, so we're a bit short on nursing, but we're also still short on us. So we've managed to quadruple our number just in the last year, but I just want to let you know that's probably less than half of what we should be here. So we should probably have about 8 or 9 of us for this catchment area. Also, we do currently general dermatology, meaning we're seeing everything, but certain subspecialties are actually really quite important. And when you think about it, our sort of ultimate goal would be to have a training program here where we could maintain the number of dermatologists we need, because this shortage is actually not just in Kingston, it's across the country. There's probably only a couple places where we're not short. And just to give you a perspective on that, I mean, skin cancer rates are rising, but also when I went through the match to get a dermatology position, there was only 8 in Canada. So if you think about that, 5 years later, there's 8 of us being graduated. Not everyone will stay in Canada, right? So in terms of opportunities for support, there's our research side, and I know my colleagues are going to be talking about some of their interests. There's staffing. We always need more space, equipment, and with our ultimate goal of getting all these things together so we can have sort of a sustainable training program. So again, thank you for supporting us, and thank you for coming, and thank you for listening to me. And I'll take any questions.
I just had one question regarding your full body phototherapy. My husband has recently gone through that, and it has worked marvelously, but he went through several years before he could get an appointment with the dermatologist, and no one ever seemed to know anything about this phototherapy. So is this new, something very new in treatment?
This is actually something we've used for many, many years. And I think that comes also down to our teaching role, which is why, so Friday and Saturday, all 3 of us are teaching pretty much all day long. And this is for general practitioners and other people who are interested, nurse practitioners. And so a lot of what we will also be doing is if you haven't had the manpower to sort of help with the continuing medical education, sometimes it's hard for, GPs have to know a lot. They have to know everything about everything. So it's difficult to find out those sources for learning when they aren't in your proximity, because they have responsibilities too. They can't just take off and go wherever they want to go do a course whenever they want. So I think that in the future, more people will know that this is available, because this is a pretty standard therapy for us. But if it's actually not available because nobody's there to do it.
They have to have the equipment.
Exactly. And you need, it's not just the equipment, you need to have someone monitoring. So I always tell people it's, on one hand I'm telling people avoid the sun and don't get skin cancer, and on the other hand I'm saying use UV light because it'll treat your problem. And it really is, they're similar, but it's all about the monitoring and making sure that you know the risks and how to protect yourself from those risks depending on what you're doing. At the back, yeah.
Can you describe what phototherapy is?
So currently we have a narrowband UVB light. So it is UV light therapy, the same UV that I'm telling you to wear sunscreen and wear hats against. But it's actually a narrow range of this, which is thought to be less carcinogenic than getting UV light outside or broadband UVB, which is what we used to use in the old days, right?
And it's used for what?
So psoriasis, eczema, itching, vitiligo, lymphomas, so skin lymphoma. Those are probably our more common things to treat, but sometimes it's useful as an adjunct. There's some people who are on systemic therapy plus light.
I also wanted to speak about what Yuka said. This morning, the nurses informed me that in terms of phototherapy, we have actually 17 allocated spots, and right now we have 23 patients who are using phototherapy, so we're already oversubscribed. And so we could probably use, more time, more units, et cetera, et cetera. The demand is tremendous. But that's sort of what Yuka's talking about. I'm going to talk about sort of my angle on dermatology, and you're going to meet an academic dermatologist, the same as Yuka. So the outline for what I'm going to talk about today is why dermatology from my standpoint. You've sort of heard a little bit about that already. I tend to speak fast. You'll find out why in a second. So a little bit about me. And then some initiatives for funding that I think are important to think about for Kingston and for the dermatology division here. So why dermatology? If you think about it, I may be biased, but I think this is probably one of the most important medical specialties. And the reason why is because we interact through the world through our skin. It's how we interact with the environment. So touch is very important from the time we're born until we find a mate, and then when we get older and age. So the skin is something that we interact with the environment. So anything that occurs to the skin obviously perturbs how we interact with that outside environment. And one of the reasons why I went to dermatology in this sort of a patient information case, I met a teenage girl when I was quite young in medical school, and she was, I think, 15, and she was losing her hair, as you can see in this case, through an autoimmune condition. And because of that hair loss, she became depressed, dropped out of high school, did not go to university, became suicidal. And so it was a tremendous impact to see what, something like this could change people's lives. And so when we think about things on people's faces, facial rashes, full body rashes, things like this, it obviously impacts how you interact with the environment. It prevents people from exercising, going swimming, going for job interviews. And not only that, but we also deal with life-threatening conditions such as melanomas we can see here. So that's sort of my take why dermatology is important and why we obviously would benefit from your support. So in terms of my personal details, I am born in Montreal. A lot of people ask me when they see me, where are you from? What brings you to Kingston? So I've lived in Toronto, Mississauga, Barrie, Hamilton, London, Victoria, Vancouver. I've been around. I've missed the prairie provinces, so I got that. Yeah, Yuka has that covered. I do have an MD PhD, which I got from Western, and I'm an assistant professor here at Queen's. I do general dermatology at Hotel Dieu. I also pronounce it Dieu, not the Dieu. I do skin cancer at Kingston General, and we do hospital consult services. So we see some very acute inpatients who have obviously skin manifestations, often drug rashes, which are more common than you'd think. So the three cornerstones, and Yuka addressed some of this, so I'm just going to go over this quickly, but we do clinical teaching. I'm actually the quote-unquote educational director of dermatology, and I've been sort of tasked with eventually setting up the training program here in Kingston. Right now, we do medical student teaching, we do resident teaching, we have residents in internal medicine who spend time with us. And then we teach other doctors about dermatology because if you think about it, 30% of what a general practitioner sees is skin. In the time that they're in medical school, they get, if they're lucky, about 10 hours of training on dermatology. So this is a tremendous need that we're trying to catch up on often. We do a lot of research. Yuka is our research director. And so we do basic science research, we do clinical research, we hope to do clinical trials in the future, and I'm going to talk about that. And then we do obviously patient care, which is the mainstay of what we do. And that involves hospital consult service, multidisciplinary clinics, and very complex patient clinics. This is my academic background, which was talked about already. So I did a molecular biology degree at McMaster, working in microbiology, and then I did an MD PhD with work in immunology. And then I went to UBC out west and did a bunch of research there. But I also, in addition to that, have a business background. So I know I appear younger than I am, but So, yeah, I'm a dermatologist. So I actually was an auctioneer. So that's where the fast talking comes from. I was also involved in machinery sales in the pharmaceutical, food, and cosmetic industry. And then I was an internet company provider way back when there was dial-up. You see how old I am? It's dial-up. So there you go. So that's sort of a little bit of my background. And so what really, when I'm giving a talk to anybody who potentially is thinking about supporting any initiative, I have a big focus on return on investment. Because it's really important, right? If you're going to be supporting an initiative, it's important to see that those initiatives have impact in the community. And so I'm going to talk about a few things that we are looking to initiate here in Kingston. And so one of the things is photodynamic therapy, and that's for skin cancer. And this is a not really a new treatment, but something that really needs to come to Kingston. So this is photo damage, and I'm not saying a lot of people in the audience, maybe spend some time in the sun, but this is a young lady. You can see how much sun damage there is here using this special light. And so we all have had sun damage because we've all experienced sunshine. And then because of that, we obviously get, skin cancers and pre-skin cancers. And so a lot of our patients look like this who come and see us. And we obviously want to treat those. And here's some more pictures of those types of scaly red bits that are, pre-cancerous or cancerous. And so photodynamic therapy is basically a way to treat these cancers and precancers. So it involves first removing some of that crusty layer on the surface, then adding a special chemical to the surface that then gets absorbed into the skin. So we apply that to the skin like so, and then expose that to a special light. And that then homes in on those cancerous and precancerous cells. And so here's an image you can see from the left where somebody has a lot of sun damage, a lot of skin cancer. They then are exposed to this chemical. It lights up only the areas that are cancer or precancer and then takes those away. So you can see in the after image that those have been cleared. Here's another example, a lot of precancers on this person's face, then clear afterwards again. It's only photodynamic therapy, no plastic surgery involved here, so it's all dermatology is doing. So this photodynamic therapy is available in Toronto and Ottawa. And in fact, I just had a patient who went to Toronto and spent a day there getting this, and it's not available here. We don't have this. And so I think this is an important thing that we can bring to Kingston because obviously, skin cancer rates are rising. The second thing I'm going to focus on is a vascular laser. And this is for rosacea and birthmarks. And again, rosacea is one of those very difficult conditions to treat, and a lot of people have, particularly the redness or the blood vessels that you see. So this is some common images of rosacea at the top and then birthmarks in the bottom. And so the addition of a vascular laser, such as you see here, would allow us to be able to treat these. And I know that Hotel Dieu is very keen on potentially including this in the treatment paradigms that we offer. And this is a before and after picture of somebody who has rosacea. Here, again, somebody who has rosacea and afterwards. And this can be very irritating, actually, because the more of these blood vessels exist, the more itchy it is, the more irritating it is. And then, obviously, if somebody has a birthmark on their face, this can be also very debilitating. And so this allows us to treat these individuals. So, some good before and after images. Yeah. And then the final area I'm going to talk about is my research interests. And being the educational director, I sort of allowed my patients to guide me on what I should be looking at because I have very broad interests. And so the first thing I'm going to talk about is something called Hidradenitis Suppurativa. You have to say that 5 times fast. So, in 5 years in British Columbia, I saw about 4 or 5 cases of this disease. In the past 8 months, I've only been here about 8 months, I've seen about 50 cases. And it's growing. And my colleagues have seen similar numbers. And so I question, is this the Kingston disease? Because this is a tremendously high number for the catchment area. And I'm going to warn you that some of the images you're about to see may be disturbing. Because this is a very debilitating disease, a very serious disease. It's a very painful disease. So this is the manifestations that you see. It often affects women, but there are definitely men who can be affected as well. It causes painful nodules and ulcers, particularly under the arms, in the groin area, in the breast area. There's discharge that can be involved. That discharge can, be very, very smelly. You can have such pain that you can't sit down. Many of my patients come to me and say, "I'm sorry, I can't sit down because it's so painful to sit." And then often these people have to be treated with surgical modalities, as you can see in this situation. And so this is obviously a tremendously difficult to treat disease, and one we have very poor treatment options for, and that's one that's very poorly understood and needs to be studied. And so I have an immunology background, and there's a belief this is a largely immune-based condition. And so some of the causes that we're looking at are genetics, the immune system, and hormones. As mentioned, it affects more women than men. And then, of course, treatments. And so this weekend, actually, I was at a symposium where we were talking about future and treatments for this disease, which I hopefully can bring to the patients here. Secondary, or an adjunct to that, is the possible addition of clinical trials to the unit here. We often have, dermatology is an amazing specialty because we have lots of new medications that are coming about on a regular basis. Melanoma is a great example. 5-6 years ago, we had almost no good treatments for melanoma. In the past 5-6 years, we've had 7 or 8 medications that have been approved now. And so being part of that development, I think, is important. And so opening a clinical trials division might be very important in the future. And then finally, I'm going to talk about the immune system, because that's my favorite topic. So when the immune system is suppressed, we get cancer. You notice the theme again. So when we have a lowered immune system, the environment, particularly sunshine, causes progression to cancer-causing states. So we have an increasing number of immunosuppressed patients. HIV is increasing. We have organ transplant patients. We have immunosuppressed patients who take medications for arthritis. And then finally, old age. We're all getting older on a regular basis, and that's a form of immunosuppression, actually. And that's maybe one of the reasons why, as we get older, we get more skin cancer. And so one of the beliefs is that, maybe there's infection as well, maybe there's UV light with immunosuppression that leads to the development of cancer. And so the question is, can we prevent skin cancer by boosting the immune system? Obviously, that would be very beneficial instead of having to cut all these cancers out. And so I've talked about why dermatology from my standpoint, a little bit about me, some initiatives that I think are good for funding that would be very applicable to the patient population here, and things that would benefit a lot of the patients here. And with that, I will take any questions. No questions. Oh, there is a question.
Can we hear you try to sell that microphone?
No, I've retired. I do it sometimes, but you have to buy me some wine first. Okay. All right, good. There's a question back there. Yep.
Just throwing this in, when my husband was at medical school, one guy said, I'm just going off to California with an oil tank full of calamine lotion. And are you still using calamine lotion?
Oh, that's a Yuka, this is a touchy subject, right? So the calamine lotion is used a lot, overused, I think, in many cases, because obviously, itch is a big problem in dermatology, and a lot of things cause itch. And so the gut reaction of many doctors is to use calamine lotion, because that's what we were taught when we were younger. In fact, we don't like it as a standardized treatment for itch, because it tends to be drying and actually causes a rebound itch afterwards. And you can actually start the cycle where you become dependent on calamine, particularly in the hospital. And so you keep applying more and more and more of it, and it doesn't really get to the root cause of the itch. So we would prefer to actually treat the root cause, either by taking away those itch mediators in the skin, or by suppressing the cells that are causing the itch. I think that's sort of our standard. Would you agree, Yuka? Mm-hmm. She agrees. Excellent. Good.
I just wanted to thank everyone. At the microphone. Thank everyone for coming today and for your support of the Kingston Hospitals. My name is Benvon Moran, and I'm the newest member of the Dermatology Division. In fact, I think this is week 4 in Kingston and at Queen's and Hotel Dieu, so I'm very happy to be here. A little bit about me. I spent probably the first third of my life in Canada on the prairies before my family moved to Ireland. So I've only found my way back to Canada in the last 2 years after doing a Mohs fellowship in Vancouver. And then came here. So I wanted to talk about skin cancer and Mohs micrographic surgery today. So I will be telling you guys what Mohs is, because a lot of people don't know what it is, including some physicians. But first of all, skin cancer. There's 2 important points I want to tell you today. First of all, skin cancer is the most common type of cancer. There are more diagnoses of skin cancer every year than there are of the 4 other main cancers combined. And also the incidence is increasing. So this is not a problem that's going away. In fact, it's getting worse. And I know the others will agree with me that we're seeing more and more younger patients with these cancers as well, including non-melanoma skin cancer. Oh.
Closer? I
Um,
held it, yeah.
Is that better? Oh, I'm sorry. So this is definitely a problem that we're having. There are three main types of skin cancer that we treat in dermatology. The first two, basal cell carcinoma, or BCC, and squamous cell carcinoma, or SCC, are called non-melanoma skin cancer. Most of these, about 85%, are BCC, and the remainder are SCC. And then the third most common types of skin cancer is melanoma, which I'm sure you'll all have heard of. So it's very common, its incidence is increasing, and alarmingly, a lot of patients we see, particularly with non-melanoma skin cancers, such as BCC, will actually get another one or even more. So a lot of the data will capture the first cancer, but often our patients are coming back with more than one, years later. So Mohs micrographic surgery is the gold standard treatment for non-melanoma skin cancer. And these are some examples of basal cells and squamous cells here in the pictures. So with normal surgery, whether it's on the face or body with a non-melanoma skin cancer, the tumor is outlined by the physician, and then a margin of normal appearing skin is marked around it. This is then removed with a scalpel, usually down to the fat, which is just underneath the skin. So there are two problems with this. One is that a lot of normal skin may actually be wasted with this modality, and also the tumor may have little roots that are actually missed by removing what appears to be normal skin. So what we do in Mohs surgery is that we remove just around the tumor with minimal or no margin of normal appearing skin. And right away we bring this across the hall to a lab where we do immediate frozen sections on it. So we're looking all around the edge of the tumor and underneath. And the way that we have it marked on the patient, we can tell when we look under the microscope, if we see some tumor, we can say, oh, that's at 12 o'clock or 6 o'clock, or where it is, and we can go back, take that tumor away, and repeat the process again. After this is done, the defect is reconstructed. And all of these three steps, the identification of the tumor, the removal, reading of the pathology slides, and the reconstruction, are all performed by the Mohs surgeon under local anesthetic as a day case. So it is a long day in the hospital, boring, a lot of waiting around. However, when you leave, you know that your tumor is gone and that no normal skin was wasted. Now, this is really important in both cosmetically and functionally important areas, so such as your lower eyelids, the edge of your nose, your mouth. If a tumor is right here on the side of your nose and you don't need to lose the rim of the nose, that's a lot easier for the patient and as well for the physician doing the reconstruction. So here's what I've just explained, shown out in a diagram. So you can see in the top left, the visible tumor is marked out and removed with a minimal margin, but you can see if the yellow bit there is the tumor, that some was missed because that was not visible to the naked eye. However, it's identified on reading the pathology slides, subsequently removed, and the steps are repeated until the tumor is fully removed. So one other thing about why Mohs is different from normal surgery, so as well as the larger margin, which may or may not be wasted, with anything else is removed and sent off for testing, pathology is bread loaf sectioned, as we call it. So if this is your tumor, slices are taken out at predetermined intervals, and this is looked at to see is there tumor at the edge. However, you can see from the drawing on the bottom right that little we call them little tree roots of tumor may be missed, because really only about 10% of the margin is looked at. With Mohs, however, we're looking at 100% of the margin, the entire edge and the entire deep margin also. So this is what's happening in Kingston. We are developing a Mohs unit, which is going to be opening at the end of next month. I wanted to get some kind of mocked up images of what it's going to look like, and I asked my husband, who's an engineer, if he could do that, but apparently that's actually very difficult and you need special programs for it. So here are the floor plans. On the bottom right you can see 3 exam rooms. We're going to have 3 theaters where Mohs will be taking place. On the top right, with all the kind of drawings in it, is our lab. So that's where the specimens will be taken, literally removed from the patient, walked across the hall, and the slides made up straight away. This takes about 45 minutes to an hour. During this time, the patients can either stay in the room or go across to the room just to the left of the lab there, which is a dedicated Mohs waiting room. It's going to be just for Mohs patients and their accompanying family members or friends who accompany them for the day. So what happens is we can treat 5 patients every day. It takes all day. You come in, you have your first bit of tumor removed. That might only take about 20 minutes. Then you're waiting for the results. During that time, while the slides are being made, all the other patients are being treated. So everyone is cycling through all day until the tumor is fully gone, and then the reconstruction or stitching can take place. So most surgery is usually mostly used on the head and neck or other sensitive areas where there isn't a lot of skin, such as the shins or hands or feet. And recurrent tumors where the margins are not clear. And so these are just, so I didn't show any scary pictures like Mark did, but I'll just show you some pictures of our lab instead. So this is where I trained in Vancouver in Mohs. These are the Mohs technicians preparing the tissue there on the left and staining it on the right so that the tumor cells can be visible when looked under the microscope. And here we are looking under the microscope, and we have a map that you can't see to the right where we can mark. We know, look, the specimens are inked, so we know exactly where the tumor cells are so that no normal skin is wasted, and most importantly, every tumor is mapped out until it is completely gone. So this actually gives us very high cure rates, about 99% cure rate for a basal cell carcinoma, and you really don't get much better than that in medicine, I don't think. Standard surgery for a low-risk basal cell will probably give you about 95, 96% cure, although you are going to have a bigger defect. So just finally, I'll wrap up with telling you where Mohs micrographic surgery is in Canada at the moment, where we're at. So there are about 9 centres countrywide and about 15 surgeons practicing. We have Mohs in Ottawa and Toronto, and we'll be starting in Kingston at the end of next month. So thank you for your attention.
This has been a lot of years since I've had to speak, so just bear with me. Good afternoon. My name is Christine Calver. I'm 44 years old, and I am, or should say, I was a sun worshiper. I'm the oldest of 4 girls, and being a teenager in the early to late 80s, we were always in competition on who could get the worst sunburn for the better tan. We were always in competition. So to achieve this goal, we would jump into our paddle boat, paddle out to Rock Island in the middle of Opinicon Lake in Chaffee's Locks, plaster ourselves in cooking oil. And we would cook for hours. And when we returned home, our mother would be livid, constantly reminding us of our grandmother Knapp, who had 7 types of cancer. The last being malignant melanoma, which led to her passing. But I was young and I knew everything there was to know about the sun. And my famous statement to my mother always was, "No worries, Mom, it'll never happen to me." Despite the golf ball size blisters I was bearing to obtain that golden turkey tan. In 2008, I was diagnosed with aggressive malignant melanoma. It was a family friend who pointed out the pencil eraser size black flaky spot, and she stated, "Chris, I think you had better have that checked out." And as a result of 4 years of procrastination and denial, my venture began. My family doctor had explained to me that I had the best of the worst, because it had not reached yet my lymph nodes. I have had 2 surgeries on my shoulder, the second surgery requiring 36 stitches, significant amount of tissue being removed, and the bone being scraped. Body checks and blood work were done every 6 months. And my husband, now of 1 year, he's been very, very well trained in the signs to look for, and we do body scans every month. Last May, I noticed a flaky patch on my face, and my doctor had said to me that it was time to refer me to a dermatologist, and that is where I met Dr. Asai. I've had since 2 treatments in my face and another recent biopsy done, which fortunately came back benign. And my first meeting with Dr. Asai required a body scan, and her statement was to me, "I can definitely tell you were a sun worshiper. I have significant sun scarring all over my body, and once to twice a year I will require a full body scan with the advice, help, and watchful eye of Dr. Asai, I am now practicing the method of prevention is the best medicine. I'm so thankful to have her clinic located in Kingston because I know she is just a phone call away if anything arises. I still enjoy the rays of that big golden ball in the sky, but now I have to be smart about it. I've traded my vegetable oil and bikini in for a 50 sunscreen and a brimmed floppy hat. Whether a person is a sun worshiper or melanoma being genetic, in my case it is both. I have a 22-year-old daughter who now practices the method of prevention. She states she would rather be a light shade of ghost compared to the vanity of a golden tan and repercussions of the sun. Each year the sun rays are getting stronger and melanoma is becoming more common. I believe it is local clinics like Dr. Asai's that can bring more awareness to our younger generation. Thank you.
My name is Mary Dowling, and I'm a redhead. I'm a redhead. And redheads have problems with skin historically. For 20 years, I have dealt with psoriasis. The psoriasis was on my hands and my feet. And inconvenient, sore, but livable. I managed with it for a long time. In May of last year, I got into an acute episode of psoriasis where I would say 100% of my body was covered. Dr. Asai will say not quite. But I was totally covered in psoriasis. At that point, we were waiting at Hotel Dieu for the phototherapy machine to be installed, and I was probably one of the very first people that went into the unit to be treated. It changed my life in the sense that I have not had any experience without psoriasis before, and I'm now standing here before you without long sleeves on. I think out of the mouths of babes, when I had the acute episode, I had been walking around for weeks covered completely. My granddaughter hadn't seen me. So I was very conscious when I saw her to be careful about how I exposed myself to her. And I showed her what it was. She was a little horrified and sort of took it all in. As about 2 hours later, we're walking down the hall and she says to me, "Grammy, are you going to die?" So the effect of what you see is profound. It's hard for you to move forward when you've got covered in a disease like that. Her next statement was, I told my friends you weren't poisonous because she was afraid that the children around her were also worried about it. I stand before you today 100% better. I wouldn't have put on a bathing suit and got into a pool. I can now go to Aquafit and be comfortable knowing that my skin is clear enough that people aren't horrified when they see me. I can't thank Dr. Asai enough, and I really thank Hotel Dieu for giving us the opportunity to have the phototherapy lab. Thank you.
My name is Heather, and a lot of actually what Christina said applies to myself as well. I have been diagnosed with 3 malignant melanomas, the first one starting in 2003. Before we had any access to dermatology here in Kingston, I've been fortunate. I've worked at Hotel Dieu for 35 years, the first 12 of it as a nurse. And so I worked with surgeons and what have you. So I was kind of lucky in the sense that I could show something to someone and they've said to me, you know, like, you best get that looked after, which hence the first malignant melanoma was discovered, as well as the second with a different surgeon that I worked with. At the time of the first malignant melanoma, I was sent to the one and only dermatologist we had in the city, who was extremely, extremely busy. Like, I still cannot believe that she was able to handle what she did in the city. And very outspoken as she was, she might be in this room today, I don't know. She did say, "I'm too busy to look after you. You need to go to your family doctor and have your mole checks done." So I did that, but at the same time, my family doctor was not completely comfortable with what he was seeing. I had since myself became an esthetician, a registered esthetician, thinking as well, oh, this is going to help me identify what, on my own body. But at the same time, as I say, after 3 malignant melanomas, it was very uncomfortable situation knowing that I didn't have someone that could look at me and say, this needs to be looked at, or you're okay, this doesn't need to be looked at. And that was a lot of years in that space and time. And then along come Dr. Asai, and I was very, very excited to see dermatology return, more dermatologists return to Kingston. She's been wonderful. It does give me such a sense of comfort to know that if I see something that isn't right, I can go to her and she will see me and let me know if it needs to be looked at or if we need to go further. And that's basically it. It's wonderful to have this now coming to Kingston, not just for my sake, but because of every story we've heard here today and the necessity of having more dermatologists in our area, and especially the equipment. Thank you.